When we talk about mitral valve, we know this is a bicuspid valve. That's anterior leaflet and posterior leaflet. But that is a very gross anatomy, which we see in echocardiography in standard view. Posterior cusp is much smaller, anterior cusp is much bigger. But the whole thing is a very well organized engineering structure which has to be taken into mind, because they are not haphazard. You see, the anterior cusp is attached with chordae, small chordae. Then the chordae become tendinous and anchored into the cords, longer cords, which are at the tip of the papillary muscle. So the whole mitral valve apparatus consists of papillary muscle, especially the tip, then the chordae, then the tendineae, small, and anterior cusp and posterior cusp. Sharing of this anterior and posterior cusp with the papillary muscle is also very formulated, so that the anterior and posterior papillary muscle can hold the cusps in tight position during systole of left ventricle, which is a very high pressure apparatus pressure in the chamber. So, and the third part is the mitral valve annulus. It's a ring-like structure which is embedded into the muscle, and that is also known as the skeletal system of mitral valve. These things has to be taken into consideration. Now, the anterior cusp is definitely divided into three scallops. That is medial, lateral, and mid cusp. These three cusps are also represented in the posterior cusp, though they are not all that prominent. So when the mitral valve prolapse occurs, that is loosening of the mitral valve, that might be due to chordae tendineae rupture, or there might be degenerative changes in the mitral valve, or there might be due to fusion of few of the valves. So those things we have to define to the cardiologist or the cardiac surgeon when we want them to go for surgery. So try and look these things very carefully. This is now, you can see there are anterior cusp is much bigger, A1, A2, A3. This is how we define the mitral valve anterior cusp area, and P1, P2, P3 are the cusp areas which we define when we report our cases. So which prolapse is there? Posterior P2 is the most commonest prolapse, so keep it in mind. And P3, P2, and P3 are the commoner. Anterior cusp prolapse, again, there is A2 prolapse is more common than any other prolapses. Subvalvular fusion. This is subvalvular area. This chordae, they get degenerated due to rheumatic heart disease, and they get fused. There is destruction and regeneration. That's why there is a fusion in rheumatic valvular heart disease, and the chordaes get fused and they shorten and they can join each other. Mitral valve commissures can join in rheumatic fever with each other and produce a mitral valve stenosis. So defining these anatomical details will be important, which might not be seen only in the standard view. So you have to rotate your transducer to focus on them and label them that this has occurred, that the medial commissure is fused or the lateral commissure is fused. Is there any calcification in the structure? So tissue character has to be defined, because calcification will produce a very bright shadow, or if there is a myxomatous infiltration, this will produce a characteristic of a ground glass appearance, or there is a homogeneous tissue in it. These kind of structural details you have to talk about. If I move to the next slide, again, the same thing. We are defining here tricuspid valve as well. You see this mitral annulus and tricuspid annulus and aortic annulus and the pulmonary annulus. This is the skeletal system of the heart. So Above this are the atria, and below this is left ventricle or right ventricle. So this is the bony structure of heart. Not bony, this is fibrous structure, but we like to call it as a bone of the heart. And you see the whole thing is actually continuous. So whole mitral valve, tricuspid valve, and the pulmonary valve are all joined in one. So say if there is a very much mutilation of the this area of the mitral valve, that can affect the aortic ring. Or if there is a ventricular septal defect just below the aortic valve, then the ring might, here the aortic ring might become prolapse and aortic regurgitation can occur. So they are interlinked. So do not undermine this bony structure which I am talking about. And in the longitudinal section, you can see the mitral valve, aortic valve. Here is the bony structure. If there is any abnormality in the interventricular septum which supports this annulus, can lead into aortic valve regurgitation. Similarly, if there is a deformity in the mitral annulus, there can be mitral regurgitation. So as it occurs in case of mitral annulus calcification, which we will see in pathological structures